Hello, welcome to Senior Speak New Hampshire. My name is Dan Wise. I'm your host and a volunteer for AARP, which is a sponsor of this show. On this program, we talk about issues and topics related to people over 50. Today, we're going to be talking about health, not physical health or the process of aging, so much as mental health and behavioral health, because that is a increasing concern. We're all talking about mental health more these days, but I don't think there's been as much attention to the mental health issues that are specific to older folks. First, some statistics. 20% of the U.S. population is expected to be 65 years old or older by 2030. And in New Hampshire, by 2040, estimates are that 1 in 3 adults will be 65 or older. And there's an increasing prevalence of mental health and substance use disorders in older adults. Nationwide, the figure is something 10 to 14 million older adults with mental health or substance abuse issues. And looking at Alzheimer's disease, in New Hampshire, according to the Alzheimer's Association, there's 27,000 people aged 65 or older with Alzheimer's in New Hampshire, and 6.9% of people aged 45 and older have some form of subjective cognitive decline, according to the Alzheimer's Association. So clearly, those are a lot of numbers, but for the reality of what it's like on the front lines and to consider this topic further, we've invited Ray Suarez, a psychiatrist and medical director of the Senior Behavioral Health Unit at St. Joseph Hospital in Nashua, and Peter Burke, who is the community education manager at the hospital, specifically for that unit, I think, right?
Yes.
Yeah, so Dr. Suarez, Peter, it's great to have you on the show. Thanks for coming. My first question, Dr. Suarez, or can I call you Ray?
Sure.
Okay. Why should there be a specific geriatric mental health unit? Why have that as a specific type of thing?
That's a great question. You mentioned some statistics at the beginning. Mental health is changing. People are aging well, healthier, and living longer. And so we're seeing people who need more assistance as they're aging. You mentioned Alzheimer's disease and dementias in general. Alzheimer's is a form of dementia now called neurocognitive disorders. Very prevalent, and it's growing. There's about 1 in 3 people will pass away with a diagnosis of some type of dementia, which is huge, and it's costing this nation billions of dollars. They said in 2024, it's estimated it's going to cost around $360 billion to the nation. And if you project that out to about 2050, we're looking at $1 trillion that it's going to cost in just healthcare for the dementias alone. Mm-hmm. Our units, what we do, we're a 21-bed inpatient unit. We treat all types of mental health. We do specialize in dementias and the neurocognitive disorders, but we see everything: anxiety, depression, schizophrenia, bipolar, the entire gamut, including substance abuse disorders.
Yeah. Are some of those folks coming in with having lived their life with a mental illness, and then the dementia is more of something that gets added on for some other patients, or do some of those other mental health conditions develop late in life?
It's a very good question. So some patients come in where their primary diagnosis had been diagnosed early on in life. They've had a lifelong history of mental health disorder, and we treat them. Sometimes the cognitive decline exacerbates other illnesses, makes it more difficult for them to live in the community healthy. So we bring those in. And there are patients who newly diagnosed with a neurocognitive disorder coming in from the community to us.
How many other facilities are there in the state that have, that specialize in the geriatric population for mental health?
There's not that many.
You can really count on one hand how many there are. There are 3 or 4.
Yeah. Because so you're one of the larger units, and you've only been in existence since the pandemic. Is that when it started?
Yeah.
Set up at that point.
Right at the very end of 2020 is when we opened.
So, Peter, maybe you can help with this one. So, where are these folks? Where are these patients coming from?
Well, geographically, certainly, really from every corner of the state of New Hampshire and beyond. We do get some folks from southern Vermont, southern Maine, some from Massachusetts. Certainly, the bulk from New Hampshire, but every part of the state, and they come to us from a variety of referral sources, one being other hospitals. You mentioned there aren't too many beds like this in the state, so very often we might get patients referred to us by emergency departments or case management departments at some of the other hospitals in New Hampshire. After that, I would say the next category would be assisted living facilities, senior living facilities, things of that sort. Other people might come to us from the community, perhaps family members who've reached out to us and initiated an intake.
And is it usually a situation where something the person's behavior or symptoms have escalated to the point where they can't be taken care of in the setting that they're in?
Yeah, so it's always, the admission criteria is safety. So is a person an acute danger to themselves or others? Unfortunately, because of the lack of care of providers in the state, some patients deteriorate as they're waiting for an intake appointment with their outpatient providers. New Hampshire, the primary care physicians are great with taking care of the patients, but in order to get in to see a specialist, there's a long wait list, sometimes months. So when they can no longer be safely taken care of in the community, they refer to our unit.
Wow. And you mentioned some of the conditions that people have. What is the kind of care that they get in being a geriatric population? You're also doing some of there's additional support, I would think, in terms of activities of daily living and things like that. I think also we talked a little earlier. We also talked about looking at the level of medications that they're on. I wonder if you could talk a little about the influence of prescription medications on mental conditions or mood disorders.
Sure. So a lot of questions in there. We could unfold them. Very good questions. We can unfold them. So to start with the medication part of it, as we age, our body chemistry changes, our ability to metabolize medication changes, as well as we get more comorbid conditions, so medications get added on. These are not natural, and they sometimes don't play nice with other medications in our body in general. Sometimes that can exacerbate symptoms. So one prescriber might give a medication to treat one illness and another prescriber for a different illness. Maybe there's an interaction between the two. Maybe there's a side effect. Some things can look like a neurocognitive or a dementia, such as medication side effects. Sometimes the sedation or the confusion that comes along with some of those medications can look like a dementia. Sometimes depression can look like dementia, anxiety, substance abuse. There's a lot of different things that go along with that. You mentioned what goes on the unit in terms of extra care, and that I think is very important, and that's why these kind of programs are very important. I think to demystify what that looks like, because we are an inpatient psychiatric unit, And a lot of times people hear that and they get scared. They don't want to be there. They have flashbacks to things like One Flew Over the Cuckoo's Nest, things like that. That's not what we are. And as far as how the unit is set up, we're actually set up more like a nursing home than an inpatient hospital. Patients can wear their own clothes. They go to groups during the day. The nurses and the staff help with the activities of daily living. They can be seen by occupational therapy, physical therapy. They get seen by a hospitalist for their medications. If they need a specialist, they can also be seen there while I'll take care of the mental health part of it. So there's all these wraparound services that go with the patient. And meanwhile, the patient is able to move around. We don't want patients in their room during the day. So we want them out in the groups and in the hallways and interacting and things like that. So it's not a restrictive environment. It is a locked unit in terms of patients that are confused can't just walk out, but it is a voluntary unit, and so we don't keep people, against their will, and family members are welcome to come visit on the unit.
Mm-hmm. Now, what about substance use disorder as an element in the patient mix that you see? Is that something?
It's definitely growing in population that we're dealing with. When I was in training, we were told, you're not going to see these as the patients age, they kind of age out of these illnesses. But that's not true. And the patients, as I said, are aging healthier longer. And we're seeing things, alcohol abuse, marijuana abuse, all different types of substances. Anxiety, alcohol, a lot of people turn to for anxiety. The pandemic definitely increased the alcohol use across New Hampshire in general.
Yeah.
And with this population, when people get stressed, they turn to alcohol. And when they're alone and they don't know what to do, that's where they go. So we're seeing these exacerbate the underlying mental health disorders, and we can treat them on the unit as well. We're not a substance abuse clinic, so we can't treat primarily. So if substance abuse is the only diagnosis, then we can't do that. But if it's a comorbid diagnosis, we can definitely help.
Yeah. So what is the average length of stay, and how does that range? Is there a range to that?
Sure. So there's no absolute, but the average is about 7 to 10 day on the unit. Some people are longer, some people are shorter. Depends on a lot of factors, diagnosis, comorbid conditions. With a geriatric population, we like to go slower with the medications to make sure that they're on the right medications, there's no side effects. We have social work on the unit that works for discharge planning to make sure there's a good disposition once the patients get discharged.
Is that a challenge?
Disposition can be a big challenge. Primarily if it's a patient coming from the community, from their home, and then needing to go into a nursing home level of care, wait lists are long. Getting funding and applying for all these things can be a little bit of a headache. And we do have the social workers that help with the families that are there, but that can be a difficult thing.
It can be time consuming. Our social workers do a great job. They work very closely with the patients and their families, almost from the moment they walk in the door, trying to help them with some of the challenges along the way, and then sort of plotting out what's going to be an appropriate and safe discharge. But it can be challenging. And Dr. Suarez mentioned the length of stay, so it's not such an open-ended period of time. Some people might be there a bit longer, but it's always nice when a patient kind of comes in and is stabilized and back on an even keel within a relatively short period of time and is back to wherever they've come from. But we do see situations where people come to us from the community. Maybe they have been living at home, and perhaps now it's no longer appropriate for them to live at home. So that's where our social workers jump in and try to help.
Yeah. Those transitions can be really difficult. Do you have any advice for family members about how to kind of navigate, because it's a stressful it's a stressful period, and it's also can be just really difficult because it may be hard to find a place.
Absolutely.
Do you have any advice for folks about how to just navigate that with their, with their relatives?
So my best advice that I give to all families, start as early as possible. So even if your loved one does not require a higher level of care right now, they may require a higher level of care at some point. So the sooner you get involved in the process, at least just asking questions and seeing what's out there, getting finances in order, any kind of paperwork you need. Advanced directives are huge, and I can't stress that enough. Going to your primary care and getting these advanced directives done can help on the back end when the patient can no longer make decisions for themselves. Reaching out to any of the organizations, starting with your primary care office, asking to speak to a social worker there, just to open up the questioning is going to be key. And then taking a look at where the person is at this point in terms of their ability to function, and seeing how you can make changes maybe in their current living situation to keep them in the home as long as possible.
Yeah.
We're blessed with some great local resources, whether it's NAMI, New Hampshire, or some of the mental health centers. So they're great resources. So if people can tap into some of the programs that they offer, it can often be very helpful.
Mm-hmm.
I just read an article this morning. Easter Seals is providing housing, affordable housing for seniors that is accessible to them. So everything's on one level, and they can stay in the community longer.
Mm-hmm. Do you find now when we talk about mental health in general, they talk about the stigma that there might be to someone having a mental condition. How does that manifest itself with the kind of folks you deal with? Do they, first of all, I'm not sure how much dementia is present in the population that you deal with. I mean, how many of those folks are, conscious of oriented to where they are versus those that are not really
Well, I think
oriented that way.
the stigma plays into getting help sooner or later, and that people push it off. They don't want the diagnosis. They're afraid of the diagnosis, especially with dementia. It's the equivalent of the big C, cancer diagnosis that people don't want to hear.
Yeah.
But the truth is, at this point, we're moving forward with medicine and being able to help patients. And so the sooner that you get a diagnosis, the better off you'll be. We can help stave off the illness in some cases. And there are newer medications that are out there that may even help to reverse early onset dementia. So getting involved with your primary care or your local mental health provider to get a baseline of where you are cognitively is very helpful, because then we know if something changes.
Is that something that you would recommend that people discuss with their primary care doc, about getting like a screening of some sort to get a baseline? Could you talk a little more about that? Because it seems like we're talking now about kind of, well, as people get older and they might develop a dementia, what is it that they can do? What is it their family members can do to minimize the impact?
Sure. So I would recommend annually getting screened. It's a simple test. There is a test called the Montreal Cognitive Assessment, which is a quick and easy screening test. And primary care can give it, social work can give it. You just need to be trained in how to give the test. And that, I think, is good because it does give you a baseline. Because your cognition can change for a lot of reasons. Let's say you go into a hospital and you had a surgery and now you're confused after surgery. Well, is this new or is this old? And having a baseline lets us know where you are and helps to treat that, as well as monitoring through time and saying, okay, so now we know this is how your disease is progressing, because it progresses different for everyone. And again, the sooner you recognize it, the better. There's medications that we can give, changes to the home and to planning. How fast do you need to plan for the future? These types of conversations can happen, and the patient themselves can be part of these conversations while they're still early on in the illness.
I think there's been progress made in chipping away at stigma, but certainly it still exists, and it's probably tied in with some of the denial that some family members seem to be in when they first try to deal with it, or forced to deal with it.
I think the other thing that's kind of has gotten to be more recognized as an issue is the loneliness and the disconnection of folks as they get older. Although it's a problem that everybody has in a way, every level of age group at this point. But
and those things were exacerbated during the COVID period of
Absolutely.
time.
yeah. But I just think of the kind of the classic case of the older person who's living in their home. They love their home. It's been their home all their whole adult life, and they want to hold on to that. And yet it can be a very isolating experience. Is that something that you've seen with people?
It's very prevalent, and it's hard because it's a change in life status, and it's very hard for the families because the families want to give the wishes of their loved one, and then they're stuck between making a decision for their safety and a decision for what that person wants. How I like to reframe it is, if you take it back to like toddlers and what you would offer for toddlers in terms of safety, in terms of having them make decisions, sometimes you have to make that executive decision that this is not safe. And in order to allow them to continue to live safely, we may need to change the environment. And it doesn't mean getting rid of everything. It just means changing a few things to kind of meet them where they are to keep them safe.
Is it sometimes also might be reducing the levels of responsibility that they have for things, or that they have to not pay their relieve them of paying the bills or things like that? Because it seems like I've read somewhere about the sort of different kinds of memory that people have, and that there's like routine memory that people hold on to. So what about, speaking more generally about, say a family member is coming out of the hospital, they've been in for a fall or whatever, they come out and their mental status seems a little different. How does someone, maybe if they didn't do the baseline things, how quickly do they go to the doctor for that? What kind of ways can you kind of suss out, they're just getting back to where they were before versus there's a problem there?
And that's why I recommend the annual testing, because it is very difficult at that point for a couple of reasons. So we don't know the baseline at that time. It could be because of a lot of other medical factors that are going on, as well as just the stress and the changes of environment. And so we don't know if that's what's going on. And then the other part of that is that the patient is now under a microscope. And so people are paying attention to them, and they may be noticing things that they never checked before. So, I haven't asked you what today's date is and things like that, right? We don't do that in day-to-day conversation. But now, if I was concerned about your memory, I would start asking you questions. I would start digging deeper, and you might find these things that you weren't looking for before. So it may have been their baseline and nobody looked. And so that's why it can be difficult. But if there's any question, I would always recommend to go to a professional and get an evaluation.
Yeah, right. So just generally, I guess as to wrap up a little bit, what advice you have for caregivers who might be dealing with someone who's beginning to lose some of their cognitive performance abilities, how to kind of ride that out and to deal with that?
So there's two parts to that. There's the caregiver themselves, which I always encourage care for the caregiver, Because if you're the one who's caring for other people, you need to take care of yourself. If you're no good, you can't help them. You know, I give the example always that, you know, when you take an airplane ride, they say air mask comes down, put it on yourself first before you help a child or someone that's disabled. So care for yourself. There are groups out there, support groups that you can find, and I highly recommend doing that.
Mm-hmm.
The other part of that is, how do you get the help for your loved one, especially when they're resisting? Because it's very hard to say, hey, I think you're having memory problems. No, I'm not. I'm fine. Everything's fine. And I wouldn't suggest you do things like that, because you want to maintain that good relationship with the person. But what you can do is kind of go through the back door. You can say things like, if you're a spouse, schedule your own annual exam and your spouse's annual exam, and then say, hey, honey, I scheduled my annual, your annual's on this day. And then you can call ahead to the doctor's office and say, these are my concerns. Would you mind checking for memory, or whatever the concern is? And this way you can still be the good person in that person's life, and they'll still be the supportive one while getting them the help they need.
Rather than trying to do a direct confrontation type of thing. Well, that's a great suggestion. So I really appreciate you guys coming in. Is there anything that you think about the whole topic that people ought to know that we didn't cover in terms of just mental health status for older folks?
I guess we've covered it. I guess just not to get too concerned, if you can, about the stigma. As a, you know, if you're a family member, really it's in everybody's best interest just to try to deal with it head on if possible. There's no shame, and you know, it affects so many people. Yeah, and you were talking just like a doctor. If you can do something about identify early, try to get some baseline status. About how old should somebody be when they start getting? When should I'm 68 right now. When should I start having baseline? I should have a baseline status done.
I would recommend from 65 and older to do annuals. But that being said, anytime there's a question about any kind of cognitive decline, I definitely will get it checked out. They're 45 years and older. At 45, for females, it's a 1 in 5 chance of developing Alzheimer's. For males, it's 1 in 10. So if you are starting to have some questions at that point, it's better to get it tested.
Thank you, Dr. Suarez. Thank you, Peter.
Thank you.
And thank you for watching Senior Speak New Hampshire. And see you next time.